topic. I think whether at your center liver transplant is happening or not, you need to know basics of liver transplant. Why the liver transplant is a multidisciplinary approach where everybody plays a role, whether it's hepatologist, intensivist, anesthetist. But I think we have to all agree that the pivot is around a surgeon. So I thought it would be worthwhile having a surgeon for his viewpoint, his perspective, and he talks to you about the nuances of liver transplant. So I have requested Dr. Ramdeep Ray, who has product from Calcutta Medical College and has done MS and was subsequently did a fellowship in liver transplantation in Delhi. He is now back to Apollo Hospital and is heading the division of liver transplantation and hepatobiliary surgery in the Institute of Gastrosciences and Liver in Apollo Gleneagles Hospital. He has a huge experience of liver transplant and has been involved in liver transplant for almost a decade now. I have requested him to talk to you as a medical gastroenterologist and to talk to you about some of the surgical aspects which are important for even a medical gastroenterologist when you're dealing with advanced liver diseases and acute liver failure. Before Dr. Ramdeep Rai comes onto the stage, let me also announce that we have lined up 3 seminars for you for the next 3 weeks. Next Monday, we'll have 2 presentations for DNB students from Apollo Indraprastha Hospital, Delhi. The week after that, we have a very exciting talk on advanced imaging from Professor Amit Datta from CMC Vellore. By that time, the theory exam of the final year will be over. And what I have planned after the theory exam, that is finishing on 20th, to have a series of clinical bedside demonstrations and bedside cases, which we have lined up 5 or 6 of them. And the first one will be Dr. Usha Datta, head of the department of PGI Chandigarh. She will be discussing, and she would have 3 or 4 final year DNB students involved in the panel discussion, and will be discussing on a case-to-case basis. This is basically to prepare you for the practical examination of DNB final. So with that, I welcome Dr. Ramdeep Ray for his presentation on liver transplantation for a gastroenterologist. Ramdeep.
Thank you very much. I will depend on you, sir, to stop me if my audio is not audible at any point of time.
Yeah.
So thanks to the medical gastroenterologists here in our hospital. I had a very busy day, so I'll be a little chaotic with my presentation today. So again, for that. So the topic is liver transplant for gastroenterologists. I begin my talk as a surgeon among physicians with the hypothesis and strong belief that surgeons are superior to physicians. And with that firm belief, because they're 2 different kinds of philosophy, however, I think you will agree with me because you as physicians are a breed among physicians who have actually made the transition from physicians to surgeons. Because the moment you're taking out stones, the moment you're dilating strictures, you're even creating anastomoses, cystogastrostomy, so on and so forth, you have said to yourself that, yes, we believe in doing things mechanically like a surgeon. So I believe you are the new age GI surgeons. We are the traditional GI surgeons, but gastroenterologists nowadays are the new age GI surgeons. You are the cross breed between surgeons and physicians, and it's a wonderful specialty, I must admit. But it also means that you must at times switch gears and think like a surgeon in terms of understanding the anatomy, in terms of understanding the radiology. I emphasize a lot on the fact that you must understand radiology, not just in transplantation, but in gastroenterology practice, so on and so forth. Now, there are many amongst you who would perhaps be thinking to yourselves that we would not be really interested in doing transplant hepatology, but would be doing hardcore gastroenterology. Spare a moment on this thought that a person comes to you with chronic liver disease, at some point in his life decompensates, then at some point is offered a liver transplant, some point actually has a liver transplant, and if it's successful, as it happens in 90% of cases, then he goes on to live a number of years before he actually dies. Now, if you were a physician, or any physician would probably be looking at a patient during this timeline. Once the person is offered liver transplant, rarely the patient would stay with the physician. A gastroenterologist comes into the scene probably a little later, probably has a role up to liver transplant, but very often after that, it is the transplant surgeon who takes over and takes care of the patient beyond that. A transplant hepatologist may probably be actually taking care of the person beyond the liver transplant right through his life. But I urge you to be a gastroenterologist with transplant interest. A gastroenterologist with transplant interest would be able to take care of the patient through the full spectrum of his life, from CLD, decompensation, liver transplant, and death. And liver transplant is just one incident, one little milestone in the entire span of the person. So, as gastroenterologist training today, you should all have some degree of transplant interest. Spare a moment also to think about that the person whom you're treating. Spare a moment also to think about the jaundice in the eyes, but the anxiety of your patient waiting for an organ. Try and imagine that anxiety. Try and imagine what it actually means to be suffering from these things. What we often label just as hematemesis and melena, the amount of anxiety, the amount of uncertainty, and on top of that, the anxiety of waiting for an organ. As this progression happens, at some stage in cirrhosis, and do liver cirrhosis, no point talking about gastroenterologists, but cirrhosis with decompensation. The ominous complications are the ones for which we should have a transplant relatively early. When to transplant? We could look at the severity from a checkbook score perspective or from a the members anything these days. So you go in, put calculator, and then you can either have a child A or a child B or a child C patient. Similarly, you can look at a MEL score as well through a MEL calculator, which you may have on your phone. But we would use a child score mainly to decide who needs a transplant. Rarely would we use a MEL score to do that. A MEL score would be one to decide who should have a cadaver organ first. Yes, they can be used interchangeably, but a transplant would generally look at these two scores for these two purposes. To decide.
Dr. Ramadeep, please, sorry to interrupt.
Cadaver.
Dr. Ramadeep?
Yes. Yes.
Please stop share your video.
I can hear you.
And continue.
Stop your video, otherwise your voice is breaking.
Your voice is breaking, so please click
Yeah,
on
now it's okay.
And continue.
Yeah. So when we look at chronic liver disease and do these basic tests to decide the disease, when a gastroenterologist is looking at a patient with chronic liver disease, and when the patient actually comes to a surgeon, we find that the etiological workup is always very extensive whenever a patient comes from a gastroenterologist. But very often, probably not from all centers, but very often we find some of the important things that are missing. Alpha-fetoprotein levels, INR, and more often than not, the oxygen saturation. And very often we find that an adequate ultrasound or a CT scan is often missing. Yes, we have an ultrasound report more often than not, but very often we find that the ultrasound is not adequate in terms of the information that is required, in terms of small SOLs, in terms of portal vein thrombosis. Oxygen saturation levels, which are very, very, very important whenever we're looking at the possibility of hepatopulmonary syndrome, is very often missing. So probably this would be very, very important information that could be a part of your prescription. I'm sure most of you would be following this, but yes, we do find prescriptions where these information are missing. The decision making that needs to be kept in mind is the patient bad enough to need a liver transplant? And at the same time, is he good enough to benefit from a liver transplant? This balancing act is extremely important. He must be bad enough in the sense that he must have adequate decompensation to actually earn a liver transplant. At the same time, he must not be so far gone out that the risk would be almost prohibitive. Is he bad enough to need a liver transplant? Very simplistically speaking, we would say a child class A patient only with HCC may require a liver transplant. Any child class B patient with a life-threatening decompensation would warrant a liver transplant. All patients of child class C and someone with primary sclerosing cholangitis with intractable itching, which is impairing the quality of life. Very simplistically, these would be the indications. I would not go into details because we have already had a class on that. And then, is he good enough? We need to check the heart, we need to check the lungs, check all other systems, exclude ongoing sepsis. Other systems, for example, we need to look at the creatinine clearance. We need to look at the MR angiobrain carotid Doppler to have an idea about the risk of a cerebrovascular accident in a patient who is above 60 years of age. So yes, we have very extensive investigations. The major worries that we would like to pick up, if they are there in the workup, is whether there's extensive portal vein thrombosis or IVC thrombosis, whether a patient has severe hepatopulmonary syndrome. Hepatopulmonary syndrome is more common than one would anticipate, one would probably expect. So please, I would once again urge you to ensure that you check the oxygen saturation level at least once. Severe portopulmonary hypertension, if a right heart catheterization demonstrates that the pulmonary artery mean pressure is more than 45, then the risk would almost be prohibitive. If the creatinine clearance is low, you do a DTPA scan, get an exact idea of the glomerular filtration rate, and you find it is below 30, then the patient would not be a candidate for liver transplant only, but would be a candidate for liver and kidney transplant combined. Active smoking has to be advised to be stopped because active smoking is associated with high incidence of cardiovascular complications in the post-operative period and even a high risk of hepatic artery thrombosis. So this is what comes out. You see the cirrhotic liver on the left side, but you also see another liver on the right side, which is not cirrhotic, which is the liver of acute liver failure, which is the liver of necrosis. And you can find the color is very different. The surface nodularity is much less, but the color is that of necrosis. So once the liver is out, where do you go with a begging bowl in hand looking for a liver? Unfortunately, in India, road traffic accidents are common and unfortunately very often leads to death. But another tragedy follows where, along with probably a brain dead person, many healthy organs are burnt alive. If only many lives could have been influenced, many lives could have been saved if those organs were utilized. So spare a moment to pledge your organs, to tell your near and dear ones whether at all you yourself would ever consider organ donation if, heaven forbid, you were brain dead on a ventilator in an ICU. But till the cadaver brain death revolution, till the deceased donor organ donation revolution really spreads through the country, the solution is living donor liver transplant, or LDLT. This is the story of Prometheus and Zeus. So Zeus was the god of fire in Greek mythology, and Prometheus stole fire from Zeus and gave it to mankind. Zeus was obviously angry that why fire was given to mankind, and he gave a punishment to Prometheus, and this is the punishment that has been depicted here. You see below, Prometheus is lying there, chained to a rock, and a vulture has been sent by Zeus to come and tear open his abdomen and eat up his liver. So the vulture comes, tears his abdomen, eats a part of the liver, flies away, comes back the next day to see that the liver has grown back. Angered, the vulture does the same thing again, eats the liver, goes back, but next day again the liver has grown back. So every day the liver grows back. Why? The idea is the liver grows back so that Prometheus would not die, and Instead, the vulture would be giving him pain every single day, and he is trapped in eternal suffering. But the lesson that we liver surgeons learn from this is that the liver grows back. And that is the basis of living donor liver transplantation, where when we donate, where we take out about 60 to 70% of the liver, the right lobe, and the remaining 30% grows back to near normal size within a few weeks. That is the beauty of the regeneration of the liver. How many livers do we have? No, it's not one. It's actually 8 livers. 8 small livers which are packaged as one. If you have nothing better to do, you can go and cut up some white mice, and you will see in the white mice, all the 8 livers are lying separately. They are not even packaged as one. There are 8 separate lying lobes with separate arteries, veins, and as evolution happened, the packaging became such that they were packaged as one. And when we are doing living donor liver transplantation to an adult, the right lobe is usually given, which is segment 5, 6, 7, 8. If it's a small adult or a young or a child, then we give segment 2, 3, 4A, and 4B. If it's a very small child or an infant, then we would give only segment 2, 3. And when we operate on transplants on children who are below 6 kilos of weight, then probably we'll be giving only a mono-segment graft. We give either segment 2 or segment 3. Now, this is a rough idea about the transplant process. What happens in a transplant is that some of the structures are removed. So there are 3 basic areas in which we dissect. One is in the porta, which is kind of below the liver. And then we operate behind the liver, which is the retrohepatic dissection. That's where the IVC is. And we also operate at the top, which is called the suprahepatic dissection. So we have a porta dissection, which is where you operate on the hepatic artery, the portal vein, and the bile duct. A retrohepatic dissection, which is of the IVC behind the liver, and a suprahepatic dissection, which is of the IVC or hepatic veins at the top. So what we do in liver transplantation is we just take this entire thing out by dividing the inferior vena cava, by dividing the bile duct, by dividing the portal vein, the hepatic artery, and so on. And this is what is taken out. That is the diseased liver taken out. And we now need to put in a new liver. The new liver is placed here, and this is the joining, the things that are joined. So we use the graft IVC is joined to the recipient IVC. The graft portal vein, which I've written as G, portal vein is joined to the recipient, and the common hepatic artery to common hepatic artery, bile duct to bile duct. And so this is a completed liver transplantation where all these things are joined. Think about this. Is liver transplantation actually liver surgery? Did we actually operate on the liver at all? Actually, we did not even touch the liver. All we did was we cut the pipes which are going to the liver or the pipes which are coming out of the liver. And then we join those pipes. So what we do is basically what we call plumbing, the job of a plumber, where we are only joining pipes. How have we done any liver surgery in this? Not really. It's a surgery around the liver. So it's basically vascular surgery. So liver transplant is actually a vascular subspecialty of GI or HPV surgery. It's not liver surgery, but this is liver surgery. This is liver surgery because we are dividing the liver. And that is what living donor liver transplant is. It is liver surgery plus vascular surgery. What is the principle of living donor liver transplantation? The entire liver is usually taken out, and half of the liver is then given in and placed here. And we find that the half liver or the hemi-liver is joined. So you go in with a full liver, but you come out of OT with half a liver. Contrast to a kidney transplant, in which a recipient goes into the OT with 2 kidneys, but comes out with 3. Because kidney transplant surgeons, what they do, they just put in another kidney. But in liver transplantation, we usually have to take out the liver and replace it with half a liver. And that is because in most cases, the patients also have portal hypertension. So unless the liver is replaced, the portal hypertension cannot be removed. Unless, of course, rarely we could do something like an auxiliary transplant for a patient with an acute liver failure, where you feel that it may have some role, although auxiliary liver transplant has not really caught on. But for the large majority of cases, we are looking at the liver being replaced by half a liver in living donor liver transplant and a full liver in case of a cadaveric liver transplant. Who can be a donor? Usually it is a first degree or a second degree relative. ABO compatible means A can receive from A or O. B blood group recipients can receive from B and O. AB are the universal recipients, and O can receive only from O. We have a detailed list of tests, including things like a CT scan. A CT scan is very, very, very important for multiple reasons. You can look at the brightness of the liver or the attenuation of the liver on a plain CT scan, compare it with the brightness of the screen, which is believed to be relatively constant in most patients. And the difference between the liver and splenic brightness or attenuation is what is called the liver attenuation index. And if the liver attenuation index is more than +5, we are comfortable that this is not a fatty liver. As the liver attenuation index becomes negative, the liver starts becoming looking darker as compared to the spleen, and we can say it's a fatty liver and may not be the best donor whom we have. A CT volumetry is very, 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 very important. It gives you an idea about the size of the right lobe, the size of the left lobe. Once you have done a CT volumetric reconstruction, you get an idea, then you have to assess. So if you're giving the right lobe, what remains in the donor is the left lobe. Now, we need to keep at least 30% of the liver behind. Maybe we can get away with 28 or 29% in some cases, but we generally become very uncomfortable about leaving anything less than 30%. So the left lobe in the donor has to be more than 30% of the total liver volume. So if I have a donor, potential liver donor, whose left lobe is 25%, then I cannot take out the right lobe. I will be risking post or post donation liver failure, which is just not acceptable. So the remnant left lobe has to be around 30% or more. At the same time, we also have to get an idea about the right lobe, because that is what is to go to the recipient. And we need to know the recipient body weight, and the right lobe predicted weight has to be 0.8% of the recipient body weight. So if we have a recipient, so what we have is called a GRWR, which means graft is to recipient body weight ratio. So we would be happy if it is above 0.8, but we can even go down sometimes up to 0.6. There are lots of papers which show that they're relatively safe, but anything less than 0.6 becomes really, really, really risky. So volumetry tells us an idea about the GRWR, graft is to recipient weight ratio, as well as the remnant volume. When we were young, when we were students, the liver used to be opaque. It used to look like this. Nowadays, the liver looks like this. It is transparent. It no longer looks like this. The liver looks like this, believe me. And why this is possible is because of radiology. Because of radiology, we can actually look at the liver in this way. And that is why it is possible. It is obsolete nowadays to look at CT films like that. Looking at CT films like this is trying to get an idea about a movie by looking at 20 or 30 still photographs. It just doesn't make sense. You must go down to the CT department, sit down, and play around with the different options that you have so that you can see arteries like this. You cannot look at arteries as little dots on axial CT films. You have to be able to see these kind of MIPT images where you can get an exact idea like in the anatomy books. Veins, you must be able to see all the segmental branches inside the liver. And it is not just for living donor liver transplantation. It has implications in liver tumors as well. You need to look at portal veins, branches. You need to start looking at the bile duct, not just lower down for stones, not just for tumors, but including all the branches, the patterns of branching of the joining confluence of the right and left, the anterior and the posterior ducts. And this is the kind of image that is possible with software reconstruction on CT, where you get all the segmental veins which are branching, which are joining into the middle, right, and left hepatic veins. Is division of the right-sided structures like the right hepatic artery, the right portal vein, the right-sided bile ducts, and also the right and sometimes middle hepatic veins. Entire liver parenchyma along the ischemic plane of the Cantley's line, and that is how the entire right lobe comes out. So you have the entire right lobe with some orifices, divided ends of some pipes like the duct, the artery, the portal vein, and the hepatic veins ready to be joined. So this is, right, you can see a donor where you can actually see the IVC behind. So what the view that you have is retrohepatic IVC, where you have the right hepatic vein slung, the inferior hepatic vein slung, and this is the right portal vein. The right portal vein, the dissection that is going on. This is the dissection in the hepatoduodenal ligament, where you're slowly dissecting and identifying the structures. So here you can see that the portal vein is visualized. Why you need to understand the anatomy is not just for liver transplantation, but this is the area that you go in when you're doing all the procedures on the bile ducts. So it is important to have an idea. It is important to visit the OT. Budding gastroenterologists should spend some time seeing the actual structures in the OT to know the procedures with the view from the actual view, not just the radiological view. And you will more often than very often be called into the OT to sometimes do certain procedures intraoperatively as well. So here we are dissecting the structures on the right side. Now, if you look at the CT picture here, and you can see the planned area of transection of the right portal vein, and that is exactly what I'm trying to do. Now, the basic rule is that if I see something at surgery, and if it is in contradiction to what I have seen on CT, then what I'm seeing with my naked eyes is probably wrong. What I'm seeing on CT is probably correct. So CT is what I have to recreate the CT image in the OT itself. And here you see, this is exactly where my sling is going to loop the right portal vein. Now, the portal vein has different anomalies, and you can have different kinds of junction of the right and the left portal vein. So in case of the type 1 anatomy, you have a right and a left portal vein very clearly. But in case of the second image, you see that it's almost a trifurcation pattern where the main portal vein divides into three different structures: the left, the right anterior, and the right posterior. In case of type C, it's almost separate, but C type D, the right anterior portal vein and the right posterior portal vein, they are very, very, very far away from each other. The implications are not just in terms of donor, the implications are also in case of a tumor which is involving a right portal vein versus a tumor which is involving a right posterior portal vein. The implications for treatment are very, very different. If I am not aware of the anatomy, then I would be only looping one of the right portal veins, probably only the right posterior, when I actually need to loop the right anterior and posterior as well. So it is important to understand the anatomy. We also need to dissect other structures. Like here you can see we are dissecting the right hepatic artery. Again, we have the CT and we are looking at the CT, and then we know exactly which is the same area to loop the right hepatic artery. It is very important to be meticulous, to have a bloodless field, because in the donor, we don't want things to get messy at any point of time. On one side, you see an image where there is one right hepatic artery, but you see the other CT where there are two right-sided hepatic arteries. So you can see in this particular image where we have identified and dissected out the two arteries. And unless I had the CT, I could have injured one of them unknowingly. This is the ischemic plane. The ischemic plane demarcates between right and left. How we do it is we clamp temporarily the right hepatic artery, we clamp the right portal vein, and the right side of the liver becomes congested. And then you mark it like this, and then you decide to divide the liver along that plane. But not only do you need to divide the liver, you also need to divide the bile duct. So this is an intraoperative cholangiogram where you see the right-sided anatomy is not standard. You're seeing that there are two ducts which have to divide, and we have to plan where we are going to divide the bile ducts, not just where we are going to divide the liver. We use different instruments like the Cavitron ultrasonic aspirator, CUSA, to divide the liver. This is a CUSA in action. The liver has two hepatic arteries predominantly, right and left. It has two portal veins, right and left. It has two bile ducts generally, right and left, or at least right-sided bile ducts and left-sided bile ducts. But the liver has three hepatic veins, the right, the middle, and the left. That is special about the hepatic drainage of the liver compared to the artery and portal vein. So when you're dividing into a right lobe and the left lobe, the right hepatic veins is on the right, left is on the left, but what happens to the middle hepatic vein? Which half gets the middle hepatic vein? Do you divide the liver on the right side or the left side of the middle hepatic vein? That is the dilemma of living donor liver transplantation. We can spend hours discussing that, but when we are taking the right lobe with the MHV, suppose we take it out, then what happens is we are going to block off the venous drainage of segment 4B in this picture. So we leave behind a congested, undrained segment in the donor. On the other hand, if we take the right lobe without the MHV, then what happens is we have multiple openings which need to be reconstructed in the recipient, but the middle hepatic vein drains the entire left liver separately, and that is the preferred one because it is donor safe. You don't leave any congested segment in the liver. The decision to in an individual case is multifactorial, but in general, keep in mind that a right lobe graft without the MHV is a donor safe policy. In this particular case, we have taken a right lobe graft without the MHV, and therefore you see the orifices on the cut surface of the liver, which need to be then joined. So here you have a segment 5 and 8 veins, which are undrained. This is a CUSA in action where we are dividing the liver. You can see that so long as we are in the appropriate plane, we are able to maintain a relatively bloodless field. So here it's a CUSA in action. And here we are looping the right hepatic duct. You see we have a cholangiogram and we are looking at the cholangiogram. Here by right angle is looping the right hepatic artery, the right portal vein, and the right duct as well. And we are going to sling just the right duct. We do not want to bear the right duct at any point of time. And it's a very meticulous dissection around the right duct because we don't want to go too far on the left or too far on the right either way. And we want the dissection here to be a little messy. We don't want the dissection here to be very clean because there's a little bleeding around when I've divided the bile duct, not just a little speck of bile, but also some blood. We are happy because this means that the vascularity of the bile duct is preserved. If you can identify, there's a little septum we can see here on the recipient side. And this is where we are ready to take out the liver. That is the right hepatic artery, which is now being tied. And behind you can see the portal vein. So when we take out the liver, the blood supply till this moment is intact. This is when we divide the artery. The moment we divide the artery, ischemic damage to the liver starts. So this is the beginning of what we call warm ischemia. And this goes on till we actually take out the liver within a few minutes and put it in ice when cold ischemia begins. So we have divided the right hepatic artery. Now we will clamp. You see, I'm looking for the orifice to see whether, yeah. So you can see the hepatic artery orifice is nice, healthy. There's no dissection. We are now going to clamp the right portal vein without damaging the main portal vein, without causing any narrowing on any left-sided structure. And we are going to divide the portal vein. And after that, we are going to divide the hepatic vein using staplers. So this is the right portal vein, which is now being divided. And after that, you can see that there is a segmental vein on top with the sling, and we will use staplers. You see here staplers to divide that. And after that, right hepatic veins remains. And so we are dividing, and then we go on forward. And here you see that the two halves have been separated. The right lobe is in ice and kept in UW, University of Wisconsin preservative solution. And you can see that the remnant left lobe is nice, healthy colored. Here you see in the reconstruction, you see on the bench that there is a right hepatic vein, there is a segment 8 vein, there is a segment 5 vein. You can identify the right portal vein and the right hepatic artery as well. So we now need to put an interposition graft to join the segment 5 and segment 8 veins. Here we are using a synthetic PTFE graft, polytetrafluoroethylene graft, which will join the segment 5 and 8 veins. And this is the anastomosis, which has begun where you're joining the right hepatic vein. We try and create a very nice, big anastomosis. We want a good outflow. Remember this, that when we are doing a living donor liver transplantation, we are giving a half liver. When we are giving a half liver, you are giving the entire portal flow to a half liver. So instead of the flow that is supposed to go to a whole liver, we are giving an entire portal flow to a half liver. So the liver tends to get congested because inherently living donor liver transplantation is a smaller than usual liver. So it is very important that the outflow is adequate. So we make a really wide, big outflow so that the liver is nice, soft, compliant, and ready to take in that extra portal flow. Here you see that the right hepatic vein is being joined, and then you see that the graft that we have put in that is being joined, anastomosed as well. It is very important to check the portal flow. This is not an unanticipated bleeding. This is a planned bleeding that you're seeing, where you see here we are releasing the clamp on the portal vein and seeing whether the portal flow is adequate. It is a very, very difficult decision to adjust to be sure that the portal vein is adequate. It's just right. It cannot be too less, it cannot be too more, because hypoperfusion damage to the liver and hyperperfusion damage to the liver from the portal vein are not theoretical concepts. They are things that we see in and day out, wherein the role of the Doppler sonologist is so important. They must give us an exact idea of the portal flow volume. Is it too less for the size of the liver, or is it too much? Here is the portal vein anastomosis. And this is the hepatic artery anastomosis, where it is done under 5 times magnification with the loop and the bile duct orifices ready for a hepatic jejunostomy. This is around 16 sutures being used just to do the bile duct anastomosis. And this is the liver, which is already ready and has started working in the new liver. Donor safety is paramount. The most important person in a living donor liver transplant program is not the recipient, not the surgeon, definitely, it is the donor. Donor safety is very, very, very important. While we have had a very good track record so far, touch wood, but worldwide it is known that donor risk is around 0.5%. So yes, it has an operation which has to be done with meticulous attention to detail, and more importantly, the workup has to be very detailed. The standard outcomes in any good transplant program is 85.
Ramdeep, you have about 5 minutes. Ramdeep, sorry. You have about 5 minutes and then we take up some questions.
I will finish within 3-4 minutes. Thank you.
Okay.
So the success rate is around 85 to 90%. Complications are 30 to 40%, mostly manageable. After 6 months, the patient is usually on either tacrolimus and mycophenolate, or in some cases, maybe on some of the other immunosuppressants. After 2 to 3 years, typically would only be on tacrolimus. We believe we are not only in the job of changing livers, but we feel that we also change a few lives in the process. This is one of my earliest patients whom I transplanted independently for a patient with Budd-Chiari syndrome. Budd-Chiaris are the most difficult transplants to do, especially sometimes when they have thrombosed IVC as well. This is the patient happy. I was perhaps happier when the patient did well. This is a child with biliary atresia who came to us at 7 months of age. And this is the child, the mother became the donor. This is immediately before the transplant. And this is the same child 4 weeks after the transplants. Pediatric liver transplants invariably are the most photogenic. Children have very cute images, but yes, liver transplant can actually be life-changing whenever it is successful. So this is before and this is after. This is a lady. If you would have been here, I'd have asked you to guess what is the amount of ascites that that you think, and we could have betted on who would have got it correct. But I'm sure most of you will get it wrong. This lady had no ascites at all. So you see here the CT, the entire thing is actually the liver replaced by multiple hemangiomas, right down to the pelvis. And only the white specks that you see are the remnant liver tissue. When we operated, her INR was more than 10 throughout. It was a very difficult, torrid operation. Fortunately, she did well. This is an intraoperative photograph of the liver with the hemangiomas. And this gives you an idea that the size of the entire tumor is more than the width of the assistant surgeon's chest as well. So it is huge. And this is her after. And she was 60 kilos before and 29 kilos after the operation. Thanks to the lots of recipients and donors who really put forth their faith in liver transplantation as a treatment protocol. But I always like to have this picture. This is not anyone whom I transplanted. This is one of the world's first successful liver transplants. This child was operated for biliary atresia. You see before, you see the first image where she's after a transplant wearing the blue frock. And you see her cheeks are swollen because in those days, they used to get a lot of steroids for immunosuppression. And this is the same lady, a picture taken 46 years after her liver transplantation, which tells you about the potential of liver transplantation. This lady was a donor to her father, an amazing picture, a very beautiful girl. But the beauty is more if it is an anonymous donor. The beauty is more when someone donates like this lady. This girl this is a picture taken in June 2019, same girl in July 2019. And this is the same girl lying there. She was a person who had donated her organs after death and given lives and helped save many others. So please think, please discuss, whatever be the learning from this, but please at least go back home and discuss among yourselves whether we can really push forward the cause of organ donation in society, amongst yourselves, in your families. Please have the discussion. Thank you very much. And on behalf of the entire team at Apollo, thank you very much.
Thank you, Ramdeep, for an excellent deliberation. I think you made the subject very, very interesting even for the physicians. So kudos to you. Now, there are a few questions on the chat box, and I think we can discuss the subject for a long time, but then we have time constraints. So the questions which are there on the chat box, and I would just quickly go through them, is that can MRI PDFF replace CT scan for assessment of fatty liver disease in the donor before the transplant? So do we have your experience? Do we have data on MRI PDFF being used rather than liver biopsy or a CT?
MRI is being used extensively in most centers to get an idea about fatty livers. Yes, and it is believed to be better than liver biopsy simply because liver biopsy is focal sampling, whereas MRI gives you a more diffuse, a more global assessment of the liver. So yes, more and more centers are using MRI.
The only thing which I would like to add for the students is that the values which you get in MRI PDFF are not the same metrics as what you get in histology. So if somebody gives you a value of 5 on MRI PDFF, it doesn't mean that there is 5% of the liver is fatty liver. So the metrics are different. Though in a numerical value, the higher the MRI PDFF, more the chances of having the fatty liver is. So what is piggyback liver transplantation?
Yes.
And the other question, yes, let's go ahead with this answer and then we go on quickly to the other questions.
So if I may answer about the piggyback, that's more up my alley. So piggyback is, so if you saw the images that I showed you in conventional cadaver liver transplant, it was found easy to replace a part of the IVC along with the liver. So you take out the liver in the recipient, you cut the IVC above and below. So the retrohepatic IVC was taken out with the liver, and when you had the liver put in, the IVC was actually anastomosed. So you actually replaced the IVC along with the liver. This is conventional cadaveric liver transplantation. Later on, a modification came wherein the IVC was kept as it is, but the donor IVC, along with the liver, the IVC was harvested as well. So you had a recipient IVC anastomosed to a donor IVC. So you had two IVCs, one above the other, or rather one anterior to the other. It was IVC was riding piggyback on the other. So you had two IVCs, one in front of the other. So this is piggyback as compared to conventional. More and more nowadays we use piggyback rather than conventional.
So I think there are many questions, Ramdeep. So let's quickly go through some of them. Can you elaborate on cold ischemic time and warm ischemia time a little bit more? You did mention about it, but can you elaborate for the physicians?
Yes. So the moment in the donor, I tie the hepatic artery, the blood to the artery, the blood to the liver is compromised, but the liver is still in the body. So it is still warm, and there is some damage which begins from that moment. So warm ischemia begins the very moment the artery is tied, goes on as the portal vein is tied, as the hepatic veins are tied, and the liver is taken out. And once the liver is taken out, it is flushed with a preservative solution and put in ice. And that's when cold ischemia begins. So warm ischemia, the artery is tied till the time the liver is taken out. While it stays outside in the ice, it is cold ischemia. And then when you take the liver out of ice, put it back in the body, and you start joining one by one the anastomosis, once again the warm ischemia begins. So warm ischemia is in two phases, in the donor and in the recipient. Cold ischemia is entirely outside. Warm ischemia is more damaging than cold ischemia.
So are there limits when you can say how does it actually reflects into the ultimate outcome? Is if the warm ischemia time is long, or if the cold ischemia time is long, does it affect the ultimate net result of the transplantation?
Yes, more in case of cadaveric transplant, because the time cold ischemia is sometimes very long. The organs may be flown in from somewhere. So 12 hours is the kind of limit for the liver. Cold ischemia.
Okay, now
there is no clear limit for warm ischemia, but the more it is, the worse it is. You find so typically in a living donor liver transplant, we find after transplant the SGP 200, 300 maybe. In case of cadaveric transplant, it will go to 2,000, 3,000, 6,000 because of the hepatocyte damage in cold ischemia.
So there is a question, mild exception. which are the situations in which there will be mild exceptions? We did mention about it briefly, but I think somebody has asked it twice, so let's answer that.
So yes, there are many mild exceptions. We rarely think about it. It's only more your domain. But yes, HCC is typically, but in a situation like living donor liver transplant, where in cadavers also where we have very limited experience. So I think mild exceptions have very little relevance in the Indian scenario.
So there was a question is that when do you want to do a liver biopsy on the donor, and what is extended donor criteria? Is there what is the age extent? Age is a limiting factor for the donor. You did mention about less than 50 years, but is that can we have an exception to that? We're talking of live transplants.
So again, liver biopsy, whenever we find that there's a fatty liver, an LAI which is probably less than 0, or if there is any derangement in SGOT, SGPT, or if it's a patient who you feel the donor is more than 50 years of age, we would be doing a liver biopsy or an extended criteria donors. There are many ways this is what we call marginal donors. Now, living donor liver transplantation, the limits keep on getting pushed every day. So if I look at 45 as the cutoff for age, if I'm looking at a donor who is 60 or 55, 58, I would be extending my criteria. There is a paper, probably Taiwan, where a living donor donating 73-year-old recipient getting a liver from a 74-year-old living donor, the wife. Now, these are extending in terms of age. You could extend in terms of fat. Sometimes you take livers, that is extended criteria. You could extend in terms of the biliary anatomy, so on and so forth. Any time when you're extending the limits of safety is extended criteria. It's a very long topic. I could go on and on.
I think there are 3 questions which are there, and I would want you to please answer in 1 or 2 sentences if possible. What about non-blood group matched transplant? Let me just quickly finish the 3 questions and you can answer them collectively. Non-blood group matched transplant, auxiliary liver transplant, is it still being done, and is there enough space for the additional liver to be there? Do you always close the abdomen after auxiliary liver transplant or you don't? And what is the SCC perspective from your side as to whether you think Milan's criteria or San Francisco criteria or beyond? So maybe you can answer these 3 and then we'll close.
Yeah. So so ABO incompatible liver transplant is being done more and more in India as well. Yes, there is a definite role of ABO incompatible transplants. The results are not as good as compatible ones. The cost becomes more. You have to get the antibody titers down by plasmapheresis or one of the other techniques. But yes, it is done. The infective complications and immune complications are slightly higher. But it is being done, and there's no reason why it should not be a part of the armamentarium of a liver transplant program. The third question was about HCC. We would follow the UCSF criteria. There are centers who would look at any size, any number, so long as there is no macrovascular portal vein invasion or distant metastasis, but we would be uncomfortable about anything beyond UCSF, or at least if it's beyond UCSF, we would downstage it in some way, some therapy, either TACE or TARE or even external beam radiation. And we would rarely ever do a transplant where the alpha fetoprotein would be more than 10,000. And
auxiliary liver transplant is a technical problem.
Auxiliary liver transplant is not technically difficult at all. It would be technically quite straightforward. Closing the abdomen would not be an issue. If people can put in additional kidneys, we can put in additional livers. Having said that, I have no experience in auxiliary liver transplantation, and I think it really hasn't caught on as we thought it would.
Ramdeep, there are many more questions, but I think we are running out of time. In respecting the time, we'll close this. I must admit that this was a very well delivered talk, and I'm sure the students have learned quite a bit. At least I learned quite a bit.